stress. But if you hold it like this, then again that's the risk of this becoming weak. That is right.
When you are planning a subciliary, please remember a subciliary incision in the truest sense can be a lower blepharoplasty incision. And here, this incision is of particular relevance because if you don't want to do a transconjunctival and you feel you're not comfortable with the transconj, you can do a subciliary approach where you take the first skin crease within the orbit. You can use a corneal shield or you can do a temporary tarsorrhaphy. I prefer to do this incisions in a very minimalistic way in the sense, instead of injecting the local anesthesia first, which would cause obliteration of the spaces or the tissues, we would put on a very lighter kind of incision and then inject the local anesthesia for hemostasis using an insulin needle, which is much more pliable and much more easier to handle. And then you initially pass through your skin, and your dissection is done in not in layers here because the tissue thickness is very less. And you need to be very careful when you're retracting with your skin hooks or your stay sutures where you want to retract the flap downwardly because you can cause a buttonholing of the flap. Is that clear? Please be a little vocal, otherwise it becomes a monologue. We are here spending time so that you gain something. It's not about the number of approaches you do on a single cadaver. I'm sure even if you have done 2 approaches out of 20 approaches what we have taught, it becomes worthwhile for all of us.
Yes.
Okay? It's not the number of approaches, it's the quality time of spending time with your cadavers. Is that okay?
Yeah. Which is why, if you cannot do everything today, please don't worry. We are giving you time then to do whatever you're doing properly. Okay.
Can we go ahead, please? When you speak about a subciliary approach, there are different schools of thought where you have a stepped incision.
Yeah. About 2 mm below the gray line is where the marking is supposed to be. And if you want a close foot extension, that you will do this. See where the close foot is and then place your incision. That is the marking. Carefully we will inject this.
Insulin syringe is better, okay? 30
Hydro injection is always good.
No, I use insulin. Let us make it very simple. Your mentors who are standing here and talking to you, including me, we have varied opinions. I would do it this way, somebody else would do it another way. But my basic essence is, let's follow the protocol where keeping it simply simple so that it is reproducible for you guys. Don't learn 10 techniques where you get confused. Do one technique and keep repeating the same thing so that it becomes reproducible and easier to start and master that technique. And then whatever modifications you want to do, you can add on in your coming years. But from a basic point of view, follow the standard protocols. You ask me, I would possibly put in a small incision first and then give the local anesthesia. I've been doing this for years so that I don't have an obliteration after giving the LA. I would just give the incision in a very minimalistic way, including the skin, and then give the insulin. It's the same I follow even for a preauricular or any kind of incision on the face or in the neck. Somebody else would tell you that they do this. So you grasp and take what works in your hand, but the steps would be the same.
No, what he's saying is better. Stop. What he's saying is better. Just place one small incision first because that will not go away. This thing will go away, this marking will go away. So place that incision first, just the marking, then inject and only then do it like that.
Skin on subtle anesthesia. Like that.
Your initial incision is there right on the skin and then she's dissecting from the... Now essential components come into play is when you start and where you stand. Like the preauricular I spoke to you about, standing at the head end, I'm sure you all tried it. Standing at the head end and dissecting in the precartilaginous plane makes things easier. Standing at the head end and dissecting onto an orbit of this extent, doing a subciliary becomes easier because you get that plane of dissection when you're standing at the head end, rather than standing at a 3 o'clock or a 9 o'clock, because you're dissecting into the substance of the globe and you don't want to do that. Go ahead.
You will automatically find the plane which is just below the skin and subcutaneous tissue, above the fat, above the muscle.
And you,
Okay.
and whenever you're doing these kind of maneuvers, what we were taught during our postgraduate years was, when you dissect this in the subcutaneous plane, you keep your flap a little thicker so that you don't have a necrosis of the flap. And as you dissect, you would see that conventional cotton candy appearance. And once you find that conventional cotton candy appearance, you don't even need to use your dissector there. You can make some small peanuts and gently score off, and it opens the tissue spaces. Remember, most of the times, your retraction, as Arjun spoke in the morning, is not about pulling it laterally, it's about going down and pulling it superiorly. In the same direction, when you're doing for the orbit, your retraction doesn't go down, but it goes up and vertical, so that it becomes easier for you to identify your planes.
So again, just keep into the fascia, don't go down into the eye. Keep going above the fascia, touching the fascia.
And when you're doing your subciliary approach, you have two conventional ways. One is the step dissection, and the other one is the conventional way. Have you shown the conventional subciliary here, or are you doing a step?
This is below the muscle actually.
Yeah,
It's a
you're below
skin
the
and muscle.
Yeah, so
Skin
that
and
means you've taken the muscle down and then you're going on top.
No. I've said it wrong. It's below the muscle. The skin and muscle are together. So
Skin.
it was a small step, and
Okay.
then the muscle is back there,
Okay.
Okay.
and then you cut the muscle again there
You are still above, below the muscle here.
below.
Then once you reach there,
You can 1
This
second.
is the-
Pause it. See that muscle is on top. No. So yeah. So for the ectropion, as I said, right, you take one nice
Tush, tush.
non-resorbable suture and take one nice good suture here.
Yeah.
That will resuspend everything here,
That
and then
point
the
तूने बोला
frost.
ना,
Okay,
Canthus.
I'll tell you. So there is soft tissue suspension here with a non-resorbable suture, and then a frost.
you got the transfer. Oh, you're supposed to be careful. See, the muscle is here. You're supposed to be careful about either going too deep, because if you go too deep, you will be into the side, or if you go too deep above, simply damaging the target plate or coming out into the inside the eye. If you go too superficial, you will come out outside into the skin.
the
Okay,
basic essence is to leave more of muscle in the upper segment, so that what Arun spoke about, you don't want to have a ectropion or an entropion.
This is just below the muscle. What is it? You can see the muscle strands here. When you see the muscle strands, don't pull
And
down.
you have specialized orbital retractors for these kind of surgeries. Deepu, tell me if I'm spelling it wrong. Is it the Desmas retractor or the Demars?
Demas.
Desmas.
DES.
It's a
Desmas.
Desmas retractor, which has an essential role to play. If you see the oculoplastic surgeons who do approaches to the orbit, they make the transconjunctival approach or the subciliary approach a child's play. It's because the retractors, what they use, we need to learn from them. They are not their competitors. They place the Demas or the Desmas retractor within the fornix, and all they need to do is identify the inferior fornix and give the incision. Now, why did that come into my conversation is, you can use those good retractors here, which are specialized orbital retractors.
When you're placing the incision on the bone, just keep one finger protecting the nerve, protecting the eyeball, and then the muscle, which has to be incised from here. Again, if there is prolapse of the fat, don't go don't go into the fat here. You have to pull the fat down. So my section here should be a little more towards the fascia, towards the muscle.
Easier to, you make a dent and one more essential component is, when you're doing a subciliary
prolapse.
approach, once you've done the skin and the subcutaneous and you have a nice dissection process and you've seen the orbicularis oculi muscle there, with your conventional tenotomy scissors, you can make a rent coming from the lateral aspect, make a small rent and release the muscle at a lower level so that the bulk of the muscle is at the higher end. Now, these are small points to take home. Okay? This is done. Yes, this can be done, but another technique is to lateralize it, put a tenotomy scissors, make a small rent and then release the muscle. So your bulk of the muscle is in the superior flap.
Once you open up the beaks of the tenotomy scissors, you can make a
Nice cut through.
So you enter laterally.
What is the difference between this and that anatomy?
So you get a cuff of muscle to suture the post plane.
So that's there.
When you go laterally, that's the plane of dissection.
That's just the plane.
No, tell them the difference between this and this because even I haven't
So when
understood.
you have the orbicular psoas muscle,
Oculi.
you kind of have that area of dissection on the lateral aspect, which is lateral, and you can open up that very easily laterally. And once you make that entry point, you will almost want
Like
to
that,
surgeon to get a good plane.
About
And then
the-
you open
about
your
the septum.
scissors, and then you cut. It's a very clean cut.
Yeah.
And you get that virtually a standard plane of dissection with good amount of muscle to suture your.
And then,
So that's why
So you
I
want
lateral-
lateral to medial, you're saying?
lateral to medial.
yeah,
You have to go lateral to
that's what you go from lateral to medial, and once you made the total cut, then you go down for a step dissection and reflect the entire periosteum.
like this.
If you read the approaches to the patient's skeleton for Edward Ellis, in that book also it is mentioned the exact same. Even in the AO
We stop here now, then get them back. दो बार
Don't show them transconjunctival, they'll get confused. Let them do this.
keep calling them. It takes more time.
It's okay. अगर दोनों सिखाएंगे तो they'll get confused. चलना है.
All right. Finish this, na?
Yeah.
They're finished with this.
Ah.
Yeah.
It also should be a neat cut from one point to the next, like that.
Lateral to medial. Like that? That's what you meant? Now the only thing is, down is the neurovascular bundle, above we have to expose the orbital floors.
What you are seeing here, no, this is orbital fat. This
The
is orbital
quadrant
prolapse.
of
What you see, eye back will be the orbital fat. This one, which will kind of prolapse if you want to take care of the eye bags here. So there are nothing but this herniated orbital fats. So it's okay. So if you want to reach there, so transconjunctival would be a better approach because the moment you put an incision on the conjunctiva, you put your scissors and it opens up and you are into this thing. So you would like from aesthetic point of view, if you want to take care of the orbital fat, the herniated orbital fat, which creates the bag here. So transconjunctival is a much better approach. But this is what would come into this side. So this is the orbital fat. And what SOOP you get is that side. And that is SOOP, suborbicularis oculi fat. This is orbital fat.
By saying that we will not show you transconjunctival now, you go back to subciliary and then come back for the transconjunctival.